Good evening, everyone. Welcome to all to IPNA endorsed webmaster series 2022. We have an exclusive webinars only on pediatric tubular disease, and it's spanning from July 9th to August 17th. We'll have it on every Wednesday and Saturday. And today we have entered into webinar 3. And the highlight of this program is we have the polling sessions for all the fellows and trainees, and the mentioned dates or the days we'll have the polling session, and the instructions will follow in the following webinars. So today we have 3 people going to interact with us. Dr. Vaishali More is going to moderate the session. She's a consultant pediatric nephrologist and she's a IPNA fellow at BJ Vadia Hospital, Mumbai. And her area of interest is towards general pediatric nephrology, acute kidney injury, and hypertension. And she is afflicted to many hospitals, and she runs her own clinic, Tara Children's Kidney Care Center. And she has got more than 30 publications, national and international. She is also an ex-editor of Pediatric Clinics of India. She is also an ex-professor of Unit Head Pediatrics at MUHS. Over to Dr. Vaishali More to moderate the session and introduce the speakers.
Thank you, Dr. Kalaivani, and your entire team for giving me this opportunity, and also thank you very much for the kind introduction. I congratulate you for consistently every year bringing such wonderful programs to us and keeping us updated even in spite of the lockdown. It's a pleasure to introduce Dr. Jalpa Dave, who is a Vadia alumni. We also had a short span of time where we worked together at when she was with us at SRCC Children's Hospital. Dr. Jalpa is a consultant pediatric nephrologist at Patel Children's Hospital, Gujarat, and also at Parul Sevashram Hospital in Gujarat. And she has her own clinic at Tender Kidney Care in Gujarat. Her specific academic interests are critical care, glomerular diseases, acute and tubular disorders. She has also won prizes for posters as well as papers presented in IPNA and the peritoneal dialysis conference from Vadia. So she is going to talk to us about cystinosis today. My first encounter with cystinosis was a patient that I saw 20 years ago. And this particular patient had presented with severe photophobia and a lot of polyuria and polydipsia. This particular patient was diagnosed because of the photophobia. From there till now, we have come a long way, and Jalpa is going to speak to us about cystinosis. The other speaker for the day today is another dynamic young girl, Dr. Disha Patel, Bhatt, who also has done her fellowship from Vadia Children's Hospital, and she is going to speak to us about idiopathic hypercalciuria. She is a consultant pediatric nephrologist, and she is also attached to GCS Medical College and Research Center and Dr. Jeevraj Mehta Smarak Health Foundation, Jaydeep Pediatric Super Speciality Hospital. She practices in Ahmedabad in Gujarat. So today we have 2 dynamic, young, promising pediatric nephrologists who are going to speak to us on one uncommon and one relatively common disorder that we see in our practice. So over to Dr. Jalpa.
Thank you. Thank you so much, ma'am, for the generous introduction. Okay, let me share my. Is my slide visible?
Yes.
Okay. Thank you so much, ma'am. Thank you so much, Dr. Kalaivani, ma'am, and team for giving me such a big opportunity to present on such a wonderful platform with vibrant audience in front of me. Today, the topic has been given to me is cystinosis, pathogenesis, and management. So, before we go to the talk, some of you might be knowing her. She is one of the famous American drag star, Bill Peterson, popularly known as Bill Pitt. She is the one who is also suffering from cystinosis. Recently, she won a reality pageant show, and in the interview, she has shared her journey as a cystinosis patient throughout. Currently, she is 27 years old. The diagnosis for her was made in the childhood period. And you know what she said about the disease was, in her words, Nothing is unaffected by it. This disease can affect almost all organs of your body at one point of time, kidneys and eyes being the most commonly affected systems. She even had to undergo dialysis at around 12 years of age. She received kidney transplant from her own brother at around 14 years of age, and currently she is on that system in replacement and doing pretty good, right? So I just gave this example to tell you that cystinosis is definitely a difficult disease to live with, but it is not impossible to live with this disease, right? Even cystinotic patients, if managed adequately on timely basis, can have a very decent lifestyle. So with this, I would like to start my talk. Usually I do prefer interactive session on case presentation basis, but to go for that case presentation, we need to know a little bit of theory. So this talk is something about theory of cystinosis. We would be discussing the definition, the physiology, etiology, the clinical presentation of the disease, the diagnosis and management. Let's start with definition. Cystinosis is an inherited in the autosomal recessive type lysosomal storage disorder, which is characterized by defective transport of cystine out of the lysosome, leading to cystine accumulation in many of the organs, majority being kidneys and eyes. So on the top right corner in the sketch, you can see it is inherited disorder associated with cystine accumulation and mainly affecting kidneys and eyes. Few interesting facts about this disease. Cystinosis is the first treatable lysosomal storage disorder which was kind of discovered. It is the most common cause of renal Fanconi syndrome, leading to end-stage renal disease at one point of time. But yet, it is considered an orphan disease with the incidence being recorded as 1 in 1 lakh to 2 lakh population. Except there is clustering in few regions because of the founder effect, because it is autosomal recessively inherited. Little bit about history. No, this disease has been known to mankind since almost last 100 years, about a century. As early as 1903, one of the kind of, you can say controversial biochemist was Swedish. Emil Eberholden was the one who first identified something related to cystine deposition. He named this disease as a familial cystine accumulation disease. He described a child with severe growth failure in infancy who had cystine crystals deposited in his liver and spleen at the time of autopsy. And he also had a history of 2 sibling death, right? And after a few months, this disorder was labeled as Abderhalden-Kaufmann-Lignac syndrome. Kaufmann was the physician who was treating that kid, and Lignac was the pathologist who kind of identified the pathological changes. This was as early as in 1903. But it took another 3 decades till 1930s to know about the actual nature and history of this disease. Fanconi, De Toni, and Dubré recognized the renal tubular defect component of this disorder in 1930s. After almost another 3 decades, the basic pathological phenomena responsible, that lysosome are the responsible organelle for this disease, was identified. In 1982, the impaired lysosomal cystine transport was detected, and in 1987, almost 30 to 40 years from this date, therapy with cysteamine drug was came into picture. So, we have the treatment for this disease for last 30 years, but still not each and every individual is getting the treatment. Why? We will be covering in our next slides. To understand the pathogenesis, we have to go back to medical school for a bit. So we all remember lysosome, right? It is the organelle which is central to the macromolecular degradation and recycling in cytoplasm of our cell. This figure depicts very nicely the different function of lysosome. It is involved in degradation and recycling of intracellular substrate as well as some extracellular substrate with the help of late endosome. It is also taking part in signaling the nutrient sensing and control of energy metabolism with signals from nucleus. It is also taking part in plasma membrane repair with specialized secretion. In cystinosis, one of the mechanisms involved with lysosome is cystine is one of the amino acid which is produced by hydrolysis of various protein with the help of acid hydrolysis which is present in lysosome. So this cystine amino acid is then oxidized to cystine within lysosome with the help of enzyme and leading to a generation of disulfide bond. But this cystine is very poorly soluble in aqueous media, so it is not able to cross the lysosomal membrane by its own. So to cross the lysosomal membrane, this cystine molecule needs help of a transmembrane protein which is known as cystinosin. It is basically a 7-unit transmembrane protein. So with the help of the cystinosin, the cystine will be extruded into the cytoplasm from the lysosome, and during this process, even the H+ is needed, energy is needed in the form of hydrogen ATPase pump use. Cystinosis means accumulation of cystine, right? So there can be two possibilities. Either it can be excess production of cystine in the lysosome because of some defective enzyme, or it can be impaired excretion. The cystine is forming at a normal rate, but the excretion is impaired, right? So in this disease, the excretion is responsible. It occurs due to the impaired excretion of cystine from lysosome into the cytoplasm and ultimately leading to cystine accumulation in the lysosome. So as early as in 1998, the gene responsible for this cystinosin protein was discovered, that is CTNS gene, which is located on chromosome 17p13. And till date, there are more than 100 pathogenic mutations had been recorded, the most common mutation being 57 kb deletions. Cystinosis is one disease, which has a very good phenotype-genotype correlation. Meaning, if there is a severe genotype, there will be severe phenotype as well. But over a period of time, we have found that there are some people who are not matching their genotype level. So now it has been discovered that there is existence of this modifier genes responsible for the broad range of phenotypic manifestation in patients with cystinosis. So in this figure, you can see that CTNS gene, along with that 1570 kb deletion, there is also another gene, that is CAR gene is involved. So this is kind of a modifier gene which can lead to different phenotypic manifestation in cystinosis. Coming to pathology, as we know, ultimately there will be excessive cystine deposition in various organs. It may be your cornea, conjunctiva, liver, spleen, kidneys, intestine, pancreas, all of the endocrine glands. Nothing is spared from this deposition. The crystals are generally hexagonal or rectangular, and they appear birefringent under polarizing light. And out of all these organs, kidney is the first organ being affected by it, and it is the most commonly affected organ. So from the healthy kidney on the left side, ultimately the cystine deposition will lead to the sick kidney on the right side. What is the pathogenesis in kidney disease because of cystinosis? The first like if you see the natural history, first will be the proximal tubular damage, because lysosomes are mainly accumulated in the proximal tubular cells, followed by later on involvement of glomerular cells, leading to FSGS kind of a picture with podocyte disease, and ultimately it can lead to progressive chronic kidney disease because of that renal interstitial inflammation and fibrosis. So this is a very beautiful slide I had taken from Elvina ma'am. In this, you can see how the proximal tubular dysfunction occurs in patients with cystinosis. First, there will be loss of all the proximal tubular cells into urine because of that apoptosis. There will be impaired mitochondrial function, oxidative stress, etc. Ultimately leading to loss of significant proximal tubular cell mass. So because of that, There will be a typical swan neck deformity. In this picture, you can see because of the loss of PT cells, ultimately your tubule will become elongated and it can give rise to a swan neck kind of a picture, which is very pathognomic histological finding of cystinosis. The other, like after having the proximal tubular damage over a period of time, the patient might experience podocyte dysfunction leading to FSGS kind of a picture, and ultimately it will be renal interstitial inflammation and fibrosis. Why? Because of that cystine deposition, there will be pro-inflammatory as well as inflammatory cytokines and chemokines will be generated in the cell, which will damage your tubules at one point of time and can progress the patient to chronic kidney disease. In the eye, the second most common organ affected from cystinosis, the changes will be the retina can exhibit patchy hypopigmentation. There will be crystal deposition in cornea, conjunctiva, occasionally in iris, and rarely in retina as well. Here you can see on slit lamp examination, you can see the crystals which are there. Okay, so coming to types of cystinosis, there are three types. First one known as infantile nephropathic cystinosis, which is the most common and most severe one because of two severe CTNS mutation. Almost more than 90% of patients suffering from cystinosis come under this category. The other one, that is intermediate one, previously known as juvenile or adolescent onset cystinosis, in which the phenotype is a bit milder one, but they will also develop end-stage renal disease at one point of time. And last, ocular one, which was previously known as adult or late onset cystinosis, in which there is no renal failure or retinal hypopigmentation seen, only the bone marrow and corneal deposits of cystine. And the only manifestation of this ocular variant is photophobia, right? So after this pathophysiology and the types, let's relax a bit. No, they may look alike, their name may sound same, but they are not same, right? Similarly, one must remember cystinosis and cystinuria are not same at all. Cystinosis is one of the dreaded disease leading to end-stage renal disease definitely in one point of time, while cystinuria is relatively benign compared to cystinosis, in which there is just increased amount of cystine in urine leading to nephrocalcinosis, not more than that. So let's discuss the clinical features of infantile nephropathic cystinosis. As we expect, the antenatal scan in such patients would be absolutely normal. There should not be any kidney abnormalities, no hydronephrosis, no raised echogenicity. In fact, the newborn period will also go absolutely normal without any signs or symptoms. But almost all patients by 6 to 12 months of age will definitely develop few features related to proximal renal tubular dysfunction, which starts as early as 6 months of age. One should be very suspicious and one should be having a high degree of suspicion to detect the kid at this level. So the renal manifestation, as we all know, that because of proximal tubular dysfunction, they will be having signs and symptoms of proximal renal tubular acidosis. Due to impaired concentrating abilities, they will develop polyuria, polydipsia, nocturia, episodes of acute dehydration. Here comes the catch. That it's very difficult for a parent, for a mother to come with you that their child is having excessive urine. He doesn't bother until there is oliguria. So if you are suspecting from the clinical examination that the child is having some failure to thrive, one must ask the history of polyuria no matter what you are going, whether it is cardiac or any other reason, but history of polyuria must be asked for. No one is going to tell you that, okay, my kid is having increased frequency. Okay? So because of all this feature, the biochemistry will be like, that will be hypokalemia, hyponatremia, normal anion metabolic acidosis. This is one of the patients suffering from the same. So because of that proximal tubular dysfunction, that will be phosphaturia, hypophosphatemia leading to signs and symptoms of rickets. Hypercalcuria can sometimes lead to nephrocalcinosis as well. Loss of carnitine in urine can lead to poor muscle mass at some extent, or low molecular weight protein, beta-2 microglobulin, etc. will be excreted in urine. It is practically very difficult, but still this Fanconi syndrome index is something which you can take a help to diagnose proximal tubular dysfunction. That is daily urinary excretion of 21 amino acids per kg body. So it will be always more, that is around the range of 1 millimole per kg per day, while the normal value of it is only 94 to 100 micromole per kg per day. So this is all about initial years of cystinosis. As soon as the child grows, if we have not started him on treatment, by 6 to 7 years of age, the podocyte disease will set in, and gradually he will be going towards developing chronic kidney disease. The tubular losses become less prominent, and the signs and symptoms of glomerular damage will become more prominent. And if not treated, they will definitely develop end-stage renal disease by 10 to 12 years of age. This is all about the renal part of cystinosis. What are the extra-renal manifestations? So, this lysosome is also very important for melanocytes. So, because of defect in lysosomal cystine excretion, the patient might be having blonde hair, white skin, because melanocytes will also be affected. The patient will be having poor growth, and in initial 1 to 2 years of life, the patient might look like having a relative microcephaly. It's very common because the height and weight won't be increasing at the same rate as the height circumference. Regarding ocular manifestation, cystine deposits starts accumulating as early as 12 months of age, but this is a very important thing, that slit lamp examination is must to pick up the cystine deposits. Why? Because during my post-graduation and residency, I had come across one case. He was like 3 to 4 years of age. He was having this kidney failure, and he was sent to ophthalmologist. After examination came normal, and somehow it was decided that he might be having that Fanconi syndrome. Like he was getting treated for the same. Then, say around 6-7 years of age, somehow after examination was repeated, and at that time, during slit lamp, it came to occur that he was having that cystine crystals in his cornea. So they were definitely there at 3 years of age when he was examined. But on detailed evaluation of this ophthalmologist notes, it was seen that because the child was uncooperative, they have just examined him superficially. They have not done the slit lamp examination, and that's how they missed that crystals, right? The clinical features because of this deposits will be, the child might be having photophobia. He may not like to go out in sun at all. There can be constant watering of eyes. Nowadays, this can be mistaken by the child is having screen time a lot. Definitely, screen time can affect eyes, but the other symptoms should also be taken care of. Other is blepharospasm. There will be irregular and peripheral depigmentation of retina, which can, in a later date, can lead to some form of visual impairment as well. Hepatomegaly and splenomegaly. Hepatomegaly because of that cystine deposits, and that will lead to, at one point of time, portal hypertension, and because of that portal hypertension, there can occur hypersplenism and splenomegaly. There are few cases in adults who literally required splenectomy for that hypersplenism secondary to portal hypertension secondary to the cystine deposits. Out of all the endocrine manifestation, hypothyroidism is the most common. Usually it sets in by 10 to 12 years of age, and they do require thyroxine supplements. Diabetes is also common because of pancreas involvement. Muscle weakness, these are mainly seen in adult people as well, and in later age group they might have, because of the pharyngeal and laryngeal muscle involvements, there will be difficulty in swallowing, etc. Because of that restrictive movement of muscle, there will be pulmonary dysfunction, which will be reflected as a restrictive valve disease. And because of that atrophy of your interosseous muscle, sometimes in elderly age group, you might find claw hand as well. And Because it affects all the organs, the patient might be having delayed puberty and affection in his fertility level. There can be neurological dysfunction in the form of some cognitive affection as well as cardiovascular dysfunction.
Jalpa, sorry to interrupt. Like
Yeah.
your voice is echoing. Can you stay a little away from the mic? There is
Okay.
too much of echo. Yeah. Thank you.
Okay. Is it okay? Okay. So, in nutshell, your cystinosis patient can go to any of the pediatric subspecialty. It can go to orthopedic or general pediatric for treatment of rickets. It can go to endocrinologist for treatment of short stature. It can go to cardiologist for failure to thrive. It can come to you for enuresis. As I say, for parents, enuresis is something which is alarming, but the child might be passing excessive urine in daytime also, but he won't give so much importance to that complaint. He can come with hypertension. They can come with visual impairment. They can go to orthopedic because of limb deformity, because of the rheumatic changes, or they can present to you as late as having chronic kidney disease setting, that is, they can come to you in end-stage renal disease. This is just a small sketch to remember that cystinosis can affect a patient from head to toe. It can affect their brain, eyes, throat, thyroid, lung, your pancreas, liver, kidneys, your reproductive system, your bones, your muscles, everything, if not treated on the right time. Few lines regarding juvenile onset cystinosis. They usually present directly with proteinuria and end-stage renal disease. The renal pancreas syndrome are less likely to be seen with this kind of presentation. But yes, ocular manifestation will be there. And ocular onset, like ocular cystinosis or adult onset cystinosis, will be having no renal manifestation. There will be only corneal and bone marrow deposits of cystine. Okay. How to diagnose this condition? History, and history. Detailed history and high degree of clinical suspicion is very important to pick up this disease on earlier basis. And one has to look the clinical examination finding, one has to especially look for the signs and symptoms of ricket, all those widening of wrist, hypercalcuria, etc., the short stature, big blood pressure, all these things are very important. The supportive test to diagnose biochemical abnormalities of RTA, which I already discussed, that is, there will be normal anemic metabolic acidosis, there will be hypokalemia, hyponatremia, hypophosphatemia, phosphaturia, hypercalciuria, etc., etc. And what are the specific tests to confirm the diagnosis of cystinosis? The blood investigation, the only blood biochemical investigation we have is peripheral blood leukocyte cystine planting. The normal value is around 0.2 nanomole half cystine per milligram of protein. And at the time of diagnosis, the value can be as high as 3 to 23 nanomole half cystine per milligram of protein. And the ocular cystinosis patient can have values ranging between 1 to 5. And the heterozygous values are less than 1, like the one who are carriers. And the patient who is on histamine therapy from beginning will have the value as low as less than 1. And this should be actually our target when we are treating the patient with histamine. The other definite test is slit lamp examination of eye, which can be done by by 12 months of age. You can able to pick up this cystine crystal deposition and molecular analysis of cystinosis chain. Coming to management, symptomatic and specific both. In symptomatic management, because of that proximal RTA kind of a picture, there should be free access to water and toilet for the kid. One might have to talk with school authorities to allow this kid to use washroom frequently, because they are usually polyuric, polydipsic, etc. The calorie intake should be 100 to 130% of your recommended daily allowance. Supplementation of electrolyte losses, like the child might require potassium citrate, sodium bicarbonate. Sometimes this kids require as high as 10 to 15 mq per kg per day of bicarbonate supplements. Treatment of rickets. in the form of phosphate supplements with the F4 session and activated vitamin D supplements as well as vitamin D and calcium if required. Another aspect, this is again a controversial thing whether to give indomethacin or not. There are many studies which have been done for the same. Some feel that indomethacin at one point of time can affect your kidney function and can, kind of fasten the end-stage renal disease development. But some say that it might help the child's appetite and, may make his life better if given with a caution for a short duration of time. Similarly, S inhibitors for proteinuria, again, there are conflict of interest, like whether we should give it or not, because at one point it can affect kidney function. But one thing is sure from all the studies, one should never ever give both the drugs simultaneously. It should not happen that your kid is on indomethacin for polyuria and S inhibitors for proteinuria. Regarding poor growth, if you have controlled all the biochemical parameters adequately and still the growth is not adequate, then you can consider the kid for growth hormone treatment. The hormone replacement might be needed in some kids for thyroxine, even testosterone, and insulin in some patients. Renal replacement therapy if required and whenever required. Now, something about the specific treatment, that is histamine drug. So here is the mechanism of action of this drug. Here you can see in the left-sided figure that histamine will bind to cysteine in the lysosome and it will form the mixed disulfide and cysteine amino acid. Cysteine being easily soluble in aqueous medium can transport from the lysosomal membrane to cytoplasm, and further it can go towards the protein production or it can be metabolized further with the help of glutathione enzyme. And the mixed disulfide will again act with the another molecule of histamine drug and the cycle will continue. On the right side the graph, you can see the study was performed in 1976. It was basically before the drug came into market, in which you can see on the y-axis that's intracellular non-protein cysteine content and the concentration of various cysteine in the in vitro medium. So with the higher concentration of cysteine, you are able to bring down the intracellular cysteine concentration at very low level. And histamine will definitely improve kidney function survival. The tablets are available as 100, 150 and 50 mg. The dose is usually 10 to 50 mg per kg per day every 6 hours. Maximum dose in pediatric, you can go up to 1.9 gram per meter square per day. And you should start with 1/6 or 1/4 of daily dose and gradually optimize in next 6 weeks. And you have to monitor your leukocyte cysteine level. Initially every monthly, then every 3 monthly and then annually. And histamine eye drops tablets is not substitute for eye drop because the tablet won't cross the barrier, and for symptom reliefs of corneal deposits, one has to use the eye drop. There is the another study in which you can see that the patient who had received histamine have definitely good outcome in terms of creatinine clearance, and those who had never received histamine, they developed the end-stage renal disease pretty early in their life rather than those who had received the treatment. This was a 20-year single-center experience from Italy, which also again showing the first it is mainly comparing that when you have started the drug less than around 3 years or more than 3 years. The earlier you start the histamine, they found that you are able to maintain the intracellular intraleukocyte cysteine content in a very good way. Similarly, the earlier you start, it maybe you will be able to achieve your target concentration with a relatively less dose. Again, the development of end-stage renal disease can be retarded for a pretty long duration of time if we have started the medicine as early as 2 years. If you have started after 2 years, again the effectiveness might decrease significantly. Side effect, no medicine is without side effects. So this have tremendous gastrointestinal side effects in terms of vomiting or bowel, alteration of bowel habits, bad odor and bad breath, which is one of the major reasons for poor compliance in adolescent age group. Again, for developing patients, cost is the major drawback, because this medicine one needs to continue even after kidney transplant, because you need to have this medicine to prevent the deposition of cystine into other organs. And as I mentioned, oral drug is not substitute for eye drop. Availability of Cysteamine, we all know there is a major discrepancy between developed nations and developing nations. Major limitation of this use in developing countries, especially in India also, we don't have any local pharmaceutical producing this drug, and we have to import this drug from outside. And you know, the tablet, the 150 mg Cysteamine tablet cost almost 2.79 euro if it is imported from France, and almost around $1. $1 is also in US prescription. So for countries like us, it is very difficult to start this treatment in the patients who require and who are from the poor socioeconomic class. And over an average cost for say around 10 kg kit will come almost 25 to 30,000 in 3 months. So here is also one paper I found. It was published in PMC Nephrology Journal, which showed the worldwide view of nephropathic cystinosis and survey from 30 countries, which again showed they had some total of 230 patients were identified from 30 nations, and the result fell 7% of these patients from developing countries died at a median age of 5 years because of not availability of Cysteamine and not able to start the medicine. More patients had reached the end-stage renal disease in developing nations initially within a short time of evaluation of this disease. But yes, however, the renal survival was not statistically different between the developing and developed nations when the patients initiated the treatment after 3 years of age. Here again, the emphasis on early start of the medicine. We do have some foundation, one of us which is that based in Chennai NGO, that is by Dr. Chandran, that help few kids who require this medicine, but again, many kids are there which require this, and some we all need to make an effort so that this medicine can be available to us in a reasonable rate for our patient. Last, kidney transplant and cystinosis. We all know we have got excellent graft survival. Immunosuppressive regimen is similar to non-cystinosis patient. The disease doesn't reoccur in kidney graft, and parents are accepted as donors because they will be heterozygotes, and heterozygotes never develop the disease. So parents can give kidney to their kids, and Cysteamine treatment has to be restarted and continued lifelong even after kidney transplant. These are the few drugs in pipeline, like mainly all these are involved with the inflammatory process, that is immunomodulators like anakinra and anacetyl-3, like fusimine, which will block the biological activity of few inflammatory mediators. The recent kind of group of drugs which has drawn our attention is the type 2 triosidase inhibitors group of drugs, which is basically a enzyme responsible for the inflammatory loop in cystinotic tissue, but still the trials have not yet been started. It is just one drug which we may think it can help us. But this thing I found that hematopoietic stem cell transplantation, already the clinical trials have been started, and we are expecting that they will be completed by August 2024, and they are planned to enroll 6 participants and see the effect of stem cell transplant. So, take-home message will be diagnosis of cystinosis needs high degree of clinical suspicion. You know, we should be creating awareness to all the physicians or pediatricians of our knowledge, so that they should pick up the disease early. They should try suspecting tubular dysfunction in patients with failure to thrive with polyuria, etc. All patients with renal pancreas syndrome must be screened for cystinosis. Cysteamine remains the mainstay of therapy, but the earlier they start, the better result will get, and it has to be continued post-transplant as well. And few of the novel therapies are still underway to clinical trials. Thank you. Thank you for the listening.
Thank you, Dr. Jalpa. That was a wonderful presentation. You have covered almost everything. There are 2 questions in the chat box. I think we will be taking them at the end. So now we will move on to the next presentation on idiopathic hypercalciuria. Dr. Disha, you may take over.
Good evening, everyone. Jalpa, can you please stop sharing your screen?
Yes, yes, I have.
Thank you. Good evening, everyone. It gives me an immense pleasure to present in this series. So today I'm going to discuss idiopathic hypercalciuria. Just a minute. Let me make it full screen. Okay. Yeah. So we'll start with the talk. The idiopathic hypercalciuria term has been described in.
It doesn't come in full screen.
Okay.
It's not in slideshow. I think you have to go click onto the slideshow or open the slideshow and then go back and share.
Just a minute.
Next to that.
You have it next to the animations, no? Open it fully in the slideshow and then share your screen.
Okay for me, ma. I'm able to see the slide.
Okay, Disha, you have any animations?
No, not as such.
Okay, then it should work. It's visible, sir.
I can see the whole slide. Huh?
Okay, fine, sir. We'll carry it.
Disha, next to home, in the same line, go to slideshow. Ahead of that is
upon
animation.
that there is a toolbar, so I'm pressing on it and it's going to mute this thing.
Okay.
So just give me a second.
No problem. Take your time.
So basically, idiopathic hypercalciuria, the word has been coined by Albright and et al. In 1983. So coming to the other, just a second. Is it full screen now?
No, it's
No.
okay. It's okay, but slides are visible. If you're comfortable, we'll go ahead.
Okay, fine. So few facts about the idiopathic hypercalciuria. Its most common underlying metabolic risk factor for nephrolithiasis, and the prevalence of that varies in the pediatric age group between 2.2 to 6.4%. It is associated in almost 75 to 80% of the children who are having a kidney stones, and in adult patient the association varies between 40 to 50%. It can affect any age, including newborn, and it equally affects both the gender, including girls and boys. The peak incidence of the same is there in the children aging 4 to 8 years, and there is actually a high morbidity with or without lithiasis, and the reduced mineral density is the major worrisome thing about the idiopathic hypercalciuria. So let me take you to some molecular basis of the whole thing. The molecular mechanism of the tubular calcium reabsorption has been shown in the picture. In the proximal tubule, more than 60% of the filtered ionized calcium gets reclaimed, and it is basically a sodium driven water reabsorption, which is driven by a sodium proton exchanger isoform type 3, and the calcium is getting reabsorbed by the paracellular pathway, and that is by clouding 2 and 12. The sodium efflux occurs from the NK ATPase and the sodium bicarbonate co-transporter at the basolateral site. And this is the major site for the reclamation of the filtered load of the calcium. Next on the list is the thick ascending lip of the loop of Handley, where almost 20 to 25% of the filtered calcium is getting reabsorbed. Here also it is majorly driven by paracellular pathway, but Claudin this involved is 16 and 19. And it is basically regulated by CSR receptors which are there on the basolateral surface, and it is getting affected by Claudin 14 in the way that CSR itself inhibits the Claudin 14, and it further blocks the paracellular calcium reclamation from this segment. And the basolateral efflux of the chloride is getting done by CLCK, NA and ND channels from this part. And lastly, the distal convoluted tube along with the collecting tubule plays the role for the tiny fine regulation of rest of the 10 to 15% of the calcium reclamation. Here the pathway is transcellular, and it is by trans receptor potential type 5 and NCCT, and this is the also affected by sodium calcium exchanger NCX. The molecular mechanism altering the reabsorption, it affects the genetic, it is having genetic association in form of variation in Claudin 14 and CASR, and most commonly the idiopathic hypercalciuria runs in the family in form of autosomal dominant trait which is having incomplete penetrance. And the actual definition of the idiopathic hypercalciuria, it's the renal overexcretion of the calcium despite of the normal serum calcium level, and in after excluding all the secondary causes of the hypercalciuria. So urinary calcium excretion, when it is estimated by 24-hour urinary calcium excretion, it is more than 4 milligram per kg per day, irrespective of the age of the person and sex of the person. But it is very cumbersome to do the 24-hour urinary collection and estimation of the solutes clearance. So the determination of the ratios to creatinine helps in this particular scenario. The fasting urine samples are preferred, although it's not necessary to check from the fasting samples only. The higher the cutoff of almost more than 95th percentile age appropriate cutoff has been mentioned here. In infants, it's more than 0.8. In preschool children, it is more than 0.4. In children and adolescents, it's more than 0.21. Caveat here is it is actually affected by diet, diurnal variation, and the posture of the child also, and extraneous other activities also. It actually assumes that the child is having normal muscle mass for the age. So the spot urinary calcium create ratio tends to overestimate the actual calcium excretion in a child who is actually having low muscle mass. The sensitivity of the urine calcium create ratio of the spot value is around 89%, and the specificity seems to be low, which is 59%, as confirmed with the 24-hour urinary calcium excretion. To overcome the effect of the low muscle mass, we can use spot urine calcium and osmolarity ratio. It is actually a better indicator to estimate the hypercalciuria in children with a low muscle mass. So what is true idiopathic hypercalciuria? The timed estimation of 24-hour urine collection is mandatory. It's preferable to have 2 consecutive collections. It is the excessive urinary calcium excretion, and it is without any dietetic manipulation. Without dietetic manipulation is in the form of the child is on daily diet, which is having a calcium load of almost 1000 to 1200 milligram, and the protein intake of the child should not be more than 1 to 1.5 gram per kg per day. So dietary factors plays a key role in the urinary calcium excretion. being most important is animal protein, sodium and potassium, and the large carbohydrate load also is important. So animal load indirectly induces the acid load, and it promotes the skeletal calcium loss, and it causes a reabsorptive hypercalciuria. Sodium is actually an important player here. The tubular reabsorption of calcium is inhibited by the tubular sodium. So increase in the sodium intake increases the urinary calcium excretion, while the decreasing the intake significantly decreases the excretion of the calcium. Dietary potassium, which is there in the fruits and vegetables, are in the form of salts of anions, which confers good alkali load, which is either in the form of bicarbonate salts or in the citrate salts, which is ultimately being converted into bicarbonate, and it decreases the acid load overall, and it helps to counterweight the reabsorptive type of the hypercalciuria. The other important thing is the phosphorus. Dietary phosphorus, when it is in the decreased state, or whenever there is renal phosphate leak, there is by vitamin D increase intestinal calcium absorption, and it further increases the level of the urinary calcium excretion. And the calcium intake of the child should not be more than 1500 milligram per day, because increase in the dietary calcium itself causes the hypercalciuria. Other important factor is large carbohydrate loads. It is having inhibitory effect by insulin, and it causes the increase in the transient hypercalciuria. Coming to pathogenesis of the disease, there is a complex interplay between three important organs here, which is bone, the kidneys and the gut. And it is further orchestrated by hormones like 125 dihydroxyvitamin D, parathormone.
Sorry to interrupt you.
Yes, ma'am.
Please press F5 because this is getting recorded. So we need to have it on
Okay, right.
slideshow mode.
So coming to the pathogenesis of this thing, there is a complex interplay, and it is still not completely understood. Idiopathic hypercalciuria is a systemic abnormality of the calcium homeostasis, and there is an altered cellular transport of the calcium in the intestine, kidneys, and in the gut, and it is further orchestrated by the hormones, which is 125 dihydroxyvitamin D, parathormone hormone, the calcitonin levels, as well as the phosphatonins like FGF23. Pathogenesis actually has genetic background, which is, as I mentioned earlier, it is driven by the autosomal dominant pattern of the inheritance, which is having incomplete penetrance, and up to almost 50% of the patient have positive family history. We'll discuss this in detail. The first on the list is the absorptive hypercalciuria on the locus 1Q23.3 Q24, which is actually characterized by increased intestinal calcium uptake. There is a normocalciuria, normal PTH, and low bone mineral density, and it may occur in autosomal dominant trait. Then increased vitamin D receptor is also associated with idiopathic hypercalciuria. The chromosome 9q33.2 to q34.2 locus also is inherited by autosomal dominant mode, and it is a major cause of nephrolithiasis in the children. And the other last on the list is calcium sensing receptor and hypercalciuric disorder. Actually, CASR regulates the PTH secretion, and the renal tubular calcium reabsorption is also regulated by calcium sensing receptor. The both of these are actually done in response to alteration in the extracellular calcium concentration. There are basically three mechanisms which leads to idiopathic hypercalciuria. First is either it could be increased intestinal calcium absorption, type 1 being the direct increase in the intestinal calcium absorption. Type 2 is absorptive hypercalciuria, which is mediated by excessive vitamin D levels, and the decreased renal absorption of either calcium or phosphate can lead to type 3 absorptive hypercalciuria. And the third mechanism is enhanced bone resorption, that is resorptive hypercalciuria. Actually, clinical attempt to differentiate all these mechanisms, it's not possible, and it will not help in the further management of the condition. There is a picture which is showing the interplay of the all the mechanism I have discussed so far. Let me speak a little about renal calcium handling in idiopathic hypercalciuria. The role of decreased calcium reabsorption leads to is there, and there is increasing the fasting calcium excretion of the calcium, and there is also fasting hypercalciuria. Alternatively, the increased absorption of the calcium with meals causes post absorptive increase in the filtered load, and at identical serum calcium level and the calcium filtered load, the calcium excretion is really elevated. Renal phosphate handling is also affected. There is abnormal phosphate excretion. There is a partly negative phosphorus balance even in the patient with idiopathic hypercalciuria on the normal diet, and many patients may exhibit slightly decreased serum phosphate levels, and perhaps frankly low levels can be seen in almost 15 to 20% of the patient with idiopathic hypercalciuria. There is a rat model in genetically designed, which can help a lot to understand the pathology and pathogenesis.
Disha, sorry to interrupt.
Doctor,
Are your
yeah.
slides moving?
Yes, it is.
Which slide you are in?
I am on genetic hypercalciuric model of
It's not
rat
moving.
model.
You're just stuck in pathogenesis slide. The slides aren't moving.
I think it is the other. It is the other.
Disha, you're there?
I think she's logged in from two
Devices.
different places, so that's why probably the slides are moving on one and not on the other.
Disha, can you try moving your slides now? Put your slides on full screen and then you have already stopped sharing. Put your slides on full screen and then start sharing.
Ma'am, can I request you to share my slides from your side if it's possible?
Kalaivani?
You're not able to share your screen?
No, not actually.
Yeah, 1 second.
Really sorry for the whole situation. So till then, let me take you ahead with clinical presentation of idiopathic hypercalciuria. It can be in the form of gross or microscopic hematuria. The idiopathic hypercalciuria is most common metabolic.
Just wait, no, like we'll put the slideshow and then you can present. 1 second, just hold on.
Okay. Thank you, ma'am. So we were discussing the genetic hypercalciuric stone forming rat model.
Which slide you want me to be in?
The next one, ma'am.
Yeah. It's fine.
The next. It's GSH rat model. Yes, perfect. Thank you so much. So the studies in the genetic hypercalciuric rat has been demonstrated a normal calcemia. There is intestinal calcium hyperabsorption. There is increased bone resorption and the defect in the renal tubular absorption of calcium. And the alterations are there in both the proximal tubule as well as the thick ascending limb of the calcium absorption. And more calcium delivery is there to the distal tubule. The calcitriol levels which were demonstrated in the model were actually normal, and increase in number of the vitamin D receptors were there in the intestine, in the bone and the kidneys of these rats, as well as in the peripheral blood monocytes from the human with idiopathic hypercalciuria. So coming to clinical presentation, the presentation varies widely. There could be gross or microscopic hematuria. The idiopathic hypercalciuria is the most common metabolic risk factor for hematuria. The voiding symptoms in form of urinary urgency, polyuria, dysuria, incontinence, and enuresis are associated, and they are very well known. The urinary tract infection is also associated, and recurrent UTIs can be one of the presentation of the situation. There is suprapubic pain, back, flank and abdominal pain, even in the absence of urolithiasis, and less frequently, idiopathic hypercalciuria is demonstrated with the frank acute renal colic. So idiopathic hypercalciuria and urolithiasis, it has a strong association. The IH is important cause of the nephrocalcinosis in childhood. In almost 13 to 35% of the causes, it's the cases, it's the etiology. There is a risk of the nephrolithiasis increases with the increase in the level of hypercalciuria. Calcium can precipitate with the variety of urinary stone, particularly the oxalate calcium stone, which is insoluble. And the long-term follow-up shows that in up to 85% of the children can exhibit renal chalazial microlithiasis or nephrolithiasis ultimately. And the prevalence of urolithiasis in the families which is having idiopathic hypercalciuria is actually between 34 to 59. Coming to idiopathic hypercalciuria and urinary tract infection, the underlying mechanism is actually impairment of the uroepithelial. The microcrystals which is the calcium oxalate microcrystals mainly. It blocks the close contact between the bacteria and uroepithelial. It forms kind of a safe barrier for the bacteria, and thus it slows down the defense mechanism, and it prevents the mechanical removal of the bacteria via urine flow also. The microcrystal can also provide the needles for the bacteria sequestration and subsequently multiplication and full-blown UTI. It is a risk factor, a predisposing factor for the recurrent UTIs too. The frequency of the idiopathic hypercalciuria, it is higher in patients who have UTI than its prevalence in the normal population without any episodes of UTI. Children with UTI and a positive family history of urolithiasis, along with the parental consent duty, they has to be evaluated for the urinary calcium excretion, provided there is a very high association of the IH in such scenario. The recurrence of UTI may be reduced by treatment of idiopathic hypercalciuria, and there is also other part, which is recurrent abdominal pain. It is also an important, not so common symptom of presentation of idiopathic hypercalciuria. The idiopathic hypercalciuria and urinary symptoms are due to a damage in the urinary epithelium, which is caused by microcrystals, and the mechanism of incontinence and voiding dysfunction is due to calcium microcrystals, which causes irritation of the bladder epithelium, which leads to contraction of detrusor or bladder outlet relaxation, and leading to involuntary voiding. Idiopathic hypercalciuria in infancy, it's not much established towards the exact prevalence. There is no specific studies on urolithiasis due to hypercalciuria in this age group particularly. Infants with recurrent stone or microcalculi should be investigated thoroughly to look for the presence of idiopathic hypercalciuria. The association also goes high because infant formula may have increase in amount of calcium, phosphorus, oxalate, sulfates, and vitamin D as compared to mother's milk. Vitamin D given at the prophylaxis doses in the formula-fed children can cause a vitamin D excess, and therefore it can cause hypercalciuria. The major morbidity which is there with idiopathic hypercalciuria in pediatric age group is actually a bone disease. Major accumulation of bone mass occur in childhood and adolescence, with peak of that in the second decade of their life. Any interference which can lead to which can be a risk factor for reduction in the optimum bone mass, and there is increased risk of fracture in the adulthood. Reduced bone mineral density is demonstrated in pediatric patient with idiopathic hypercalciuria, and there is an inverse relation between the age of the child and bone mineral content. Age of the child meaning the age at when the idiopathic hypercalciuria has set in, and that suggests that there is an adult osteoporosis which may begin early in the childhood. Bone disease in idiopathic hypercalciuria is the major morbidity, and many studies has been conducted for that. It shows that the hypercalciuric calcium stone formers have actually decreased bone mineral density when compared to matched controls, which are neither stone formers nor the hypercalciuric one. And the reduction in BMD in hypercalciuric pediatric patient with or without hematuria or urolithiasis is noted. The progressive reduction in the mineral content suggests that there is a key role of osteoblast and osteoclast in the chain of events, and the osteoclastic and osteoblastic activities is basically regulated by major number of cytokines. The blood monocytes from the isolated patients with idiopathic hypercalciuria, they shows there are significantly increased production of cytokines, naming interleukin 1, GM-CSF, and TNF alpha. which leads to increase in the osteoclastic activity, and it produces the reduction in the bone mineral density ultimately. So densitometry is the gold standard in diagnosing the bone mineral disorder. In children, bone body density is being done, and the test result is whenever the Z-score is more than -2 standard deviation, along with the clinical symptom, osteoporosis can be labeled, and osteopenia is suggested by Z-score of -1 to -2. So there is a very nice article which is there in the IPNA recent one, 2021. It suggests the evolution of bone mineral density in the pediatric patient with idiopathic hypercalciuria, and it's one of a kind study, because a 20-year longitudinal study has been done on 34 patients, and three timed BMD has been assessed. The mean elapsing time between the BMD 1 and 3 estimation was 17.7 years, and it is not well understood why some patients showed decline in the BMD in their adolescence, and there is a reduced excretion of calcium in citrate, which has an impact on the lithogenic risk. There are two practical consensus which can be derived from this study. First is carrying out routine bone densitometry in studies routinely in IH patients. It's really not necessary. And the second is normalization of urine calcium excretion may be an indirect biochemical sign of the bone mass recovery. Coming to the next etiopathogenesis is renal tubular dysfunction in idiopathic hypercalciuria. It can be encountered in patient with urolithiasis or nephrocalcinosis as a cell crystal interaction, and it may lead to tubular damage and or dysfunction. And it is very less likely that it can be a primary cause of IH. And urinary N-acetyl beta D-glucosaminase excretion has been demonstrated that it could be either increased or normal in children with IH. Urine NAG is a marker of proximal tubular damage, and there is no direct relationship stating that there is tubular impairment and degree of the calcium leakage. Coming to the diagnosis of the idiopathic hypercalciuria, all the associated features has to be looked upon, stating failure to thrive, rickets, sustained metabolic acidosis, dysmorphic features, proteinuria of any grade, and reduction in GFR. The detailed history has been should be taken, mentioning diet and medication history of the child, and laboratory tests for blood and urine both has to be conducted to rule out the secondary causes at least. The long term, coming to the management of situation, long term management for the prevention of recurrence, aiming to reduce or prevent the emergence of new stone, prevent existing one to increase in the size, and to reduce the morbidity and need for the surgical intervention. Non-pharmacological as well as pharmacological modality is there. Non-pharmacological is approached first, which is in form of increase in dietary modification with high fluid intake, low sodium, and protein and calcium should be given to child as per the recommended daily allowance. Calcium intake cannot be reduced for the growing child, and children routinely do not comply with this recommendation, and frequently they'll end up requiring anti-calciuric therapy. So the indication for anti-calciuric therapy here is no normalization of the calcium excretion with dietary modification, and the first on the list is potassium citrate as a hypocalciuric agent. The supplementation with alkaline potassium salt, it reduces the endogenous it causes reduction in the endogenous acid, and it further reduces the urinary calcium excretion and overall reduction in the bone resorption. in pediatric patient, potassium citrate decreases the recurrence of new stones and the growth of residual stone fragments following lithotripsy, but no studies are there to confirm the beneficial effect of potassium citrate therapy on the bone mass. Pharmacological treatment with thiazide should be reserved. It is mandatory only in 3 situations: when there is marked clinical complaints such as sustained dysuria, frequent macroscopic hematuria, or recurrent renal colic. There are any histories of repeated fractures and the stones or nephrocalcinosis on ultrasonography. The thiazide has to be started. The effect of thiazide on the bone, it may extend beyond its anti-calciuric action, and probably it's related to stimulation of the osteoblastic bone formation. Bisphosphonates in idiopathic hypercalciuria. Only a select number of children with hypercalciuria and decreased BMD may need this therapy, only to be given by experts, and short-term treatment with bisphosphonates is effective, and bisphosphonate should be prescribed only and only when all other measures fail to restore the bone mineral density. Does a low calcium diet is necessary for patient with idiopathic hypercalciuria? No, because every measure has to be taken to ensure there is adequate calcium in growing child's diet with hypercalciuria. And if a child is not able to consume the calcium as per RDA, the supplementation should be done, but a low calcium diet are really not advisable. Coming to vitamin D, bone density, and nephrocalcinosis in preterm infant, there is a prospective study which was there in May 2021. The study has been conducted in 56 infants. On an average, they received 447 international unit of vitamin D, and their average serum 25 UHD level was 39.6 at the end of the therapy. The very nice conclusion can be driven from the study. It's the basically vitamin D supplementation are based on full-term infant, and which can be not a optimum or appropriate dose to be given to preterm infant. Preterm are already at high risk to develop nephrocalcinosis even without vitamin D supplementation. So the study speculates that the dosage of vitamin D on the initiation of supplementation should be almost 400 international units per day. Then it can be individualized with the close monitoring of the serum level every 2 weekly or 4 weekly estimation. And on this study, the occurrence of nephrocalcinosis has been shown on the average vitamin 25 OH vitamin D level of 45.3. And it proposes that the initial goal of the vitamin D level should be between 30 to 40 nanogram per ml and not more than 40. The effect of vitamin D treatment in dynamics of bone formation in the urinary tract and the bone density in children with idiopathic hypercalciuria. There is actually no literature suggesting what is the effect of vitamin D. Some supportive studies are there. From this study, the conclusion can be drawn that the supplementation with low doses of vitamin D, that is 400 to 800 international units a day in children with idiopathic hypercalciuria, it significantly increases concentration of 25 OH vitamin D in the serum, but it does not affect the level of calciuria. So low dose vitamin D supplementation is fine with a child having IH. It does not increase the dynamics of the stone formation in the urinary tract, but also does not improve the bone density. So neither does it having a beneficial effect on bone density, nor it is creating any new stone formation. The use of vitamin D preparation in these patients are actually safe, and children with IH should be advised for careful monitor to be supplemented along with careful monitor of the parameters of calcium metabolism and level of urothiasis activity without giving vitamin D supplementation. Many thanks, and really, I'm sorry for the interruption of the session due to technical issues.
Disha, that was fine. In spite of the technical issues, we really enjoyed your talk. It was very much in detail and you have covered almost everything. So now let us move on to the questions. There are a few questions here in the chat box also. So one question is, if I do not have any access to leukocyte, cysteine or genetic testing in children with Fanconi. So Dr. Jalpa, how to make a diagnosis of cystinosis in that case? Is eye examination is normal? Does it exclude cystinosis?
And yes, first I would like to say that now we have facility of this leukocyte cysteine contained at our very own AIMS. So AIMS people in association with ICMR do peripheral leukocyte cysteine level. So if anyone wants to do that, they can contact the appropriate channels. And yes, if in spite of all this you are not getting the level done, negative eye examination will not completely exclude. It depends when you are doing it. Usually by 12 to 24 months of age, cystine deposits do occur in almost all people. But you have to be in a close watch. It might happen that after a few months you can find, so if you are really suspecting cystinosis because of other features, you should be doing repeatedly for a few months before excluding, and by that time you can get then your peripheral leukocyte cysteine level.
Yeah, previously we never had leukocyte cysteine levels, or we never had genetic studies, and it used to be a clinical diagnosis. And as Dr. Jalpa had pointed out, many a times eye examination may have missed it, or these diseases evolve over a period of time, and the eye changes will come only after 1.5 years, 16 months to 1.5 years. So as she has rightly said, you will have to monitor the child on a regular basis. The other question is that many patients say that the eye drops are very painful. So could we dilute the eye drops?
No, ma'am, because these drops are made with very stringent formulation, and it's not advisable to dilute them. Though nowadays, they are saying that soon the gel will be available, so that can be a good option. But diluting it with normal saline is not advisable. It will definitely affect the efficacy and stuff.
Yeah, the gel I think is higher concentration, so the gel will probably be the one which is causing more burning, and the aqueous probably will be a better one. The gel advantage is that you can use it less frequently, and the aqueous has to be used for almost 8 to 10 times in 24 hours. So probably switching over to the other preparation may be an option for this for these patients who are having a repeated burning and pain. I have some questions for you, Dr. Jalpa. So what happens after transplant? The cysteamine you said will have to be continued. So what are the reasons for it? Can you elaborate a little on that?
Yes, ma'am. Yes, ma'am. Because as we saw in the pathogenesis, the basic defect is cysteine accumulation in the lysosome. So with kidney transplant, we have only taken care part of the kidneys, but there are all the other endocrine glands, bones, muscles, brain, etc., which can have the cysteine deposition and subsequent deteriorating effect on the same. So one has to carry the cysteamine, life should be lifelong. It should not be stopped after transplant.
Yeah. So when you're giving systemic cysteamine, then what is the requirement to give the eye drops? If you're giving it systemically.
Yes, ma'am, because it won't cross the barrier in eye, so they won't reach to the
There's no
cornea.
blood supply. So yeah, correct. So you said there are a lot of GI side effects. So what is the reason for the GI side effects, and what do you do with the side effect?
Yes, ma'am. One of the GI side effect, major one is vomiting, and that acidic feeling, acidity kind of a picture, pain followed by the food, etc. Because it has been seen, the reason not very clearly known, but it has been seen that the cysteamine drug itself will increase the gastrin production and increase the gastric acid production per se. So usually, mostly they prescribe that you should take this drug along with pantoprazole or omeprazole, because it can by itself can increase the gastric juice secretion. So that can be one reason for this thing. And the bad.
Correct.
Yes.
Yeah. Finish your side.
Yes, ma'am. So the bed order is mainly because of that disulfide bond which is there, and because of that they are having bed order. That is also one side effect. So these two are the major one which can lead to poor compliance.
Okay, okay. Thank you. Any other questions or any other comments from our senior faculty members who may be online? So let us move on to Dr. Disha. It was a nice talk in spite of the technical glitches, very much in detail. I really appreciate your the effort that you have taken to make this talk. You said that first and foremost is the dietary modification and the water intake. How long should one wait for the dietary modification and the water intake uh, and you know kind of before adding on the hypocalciuric treatment?
So the dietary modification of the and the increased fluid intake is basically aiming to reduce the calcium excretion. But whenever the reduction in the urinary calcium excretion is not possible to be achieved on the dietary modification as well as increasing the fluid therapy, one should switch over to potassium citrate supplementation, because as we have seen from the talk, the morbidity of idiopathic hypercalciuria is actually high in terms of micro lithiasis and urolithiasis and nephrocalcinosis. So whenever the child fails to show improvement on dietary modification and fluid therapy, potassium citrate is very well needed for the particular case.
In my practice, I prefer waiting for at least 1.5 months because it takes time for the modification to be brought about and to actually start helping the patient. There is a question: how does low salt diet decrease the calcium excretion? Can you take that?
Yes, because as whenever there is increase in the renal tubular filtered sodium level, it is going to increase the hypercalciuria level. After diminishing the sodium load in the glomerular filter, there would be decrease in the renal excretion of the calcium. In that way, reduction in the dietary salt is the first and foremost measure which has to be taken in the form of the non-pharmacological management of the hypercalciuria.
I also wanted to ask you, you quoted the BMD study, and in that study, whether they have mentioned when both thiazide and potassium citrate are given versus when potassium citrate are given, the bone marrow densitometry, is it different?
Ma'am, actually, thiazide is known to have beneficial effect in bone mineral density in adult population, but no such studies has been there to mention its beneficial role in the children. So it's not the long-term effect on the bone mineral density which is given by thiazides.
There is another question which has come up. What specific advice would you give patients in regard to protein intake?
So protein intake of the child cannot be diminished. The protein intake should be continued as per the recommended dietary allowance, but intake should not exceed more than 1.5 gram per kg per day of body weight, and the source of protein should also be not the animal source of the proteins, as it can increase overall acid load and reabsorptive hypercalciuria would be this situation later on when one consumes the animal proteins. So the nature should be not the lesser amount of the animal protein, and amount is particularly less than 1.5 gram per kg per day.
Yeah. So I think there is only one question which I think Dr. Jalpa has already answered. Are there any labs who are doing leukocyte cysteine levels? And she has already said that All India Institute of Medical Sciences is doing it for us. Any comments from any of the senior members who are online?
Sir, you wanted to ask something?
No, I just said both are excellent presentation. It's not very comprehensive. I think they should be proud of themselves for presenting such a good presentation. But I have one question to Dr. Jalpa. She has presented 2 or 3 figures and put the Jalpa down. Is there any copyright for that thing?
It is
For those
her own
pictures?
drawing, sir.
Oh, I was also whether we could use it for our slides or have to get permission from her. Because she has put Jalpa down.
Jalpa, are you around?
Yes, sir. I couldn't hear it properly. Actually, the internet. Sorry, sir. What?
No, the good pictures, so there's originality.
Sir is asking whether your drawings can be reused or we require to take permission from you.
Copyrights. Should we ask for copyrights?
No, sir. No, sir. I would be happy to share, sir. It's just my one of the, so I would be definitely happy to share.
They are very
sir.
meaningful. They are very meaningful. Those pictures are very, very meaningful.
Thank you so much. Thank you, sir.
Vaishali, there is one question which has.
Yeah, I was also looking at that only. So what is to what extent bisphosphonate can be used in pediatric? I mean, is it that medicine which is given simply? So can you take that?
Yes, bisphosphonate should not be used like a simple medicine. It's always has to be given by experts. Only in the rarest of the rare cases where the BMD is not improving by the other measures, it is given. So it's the medicine which is least commonly used for idiopathic hypercalciuria, and always 2-3 expert has to be incorporated while taking such decisions. So it's not a simply used medicine for IH.
Okay, I think, Kalaimani, I think we have answered all the questions.
Yeah. I think we have finished it on time. I think all the speakers did a great job, Disha, Jalpa, and it was well moderated by Vaishali. We'll have the next session on July 20th. And we'll start the polling session from July 23rd. And so I request all the fellows and trainees to participate in the polling session.
Okay, thank you.
Thank
Good
you
night.
so much, Vaishali. Thank you, Jalpa.
Thank you.
Despite
Thank you,
short
Jalpa.
notice,
Thank
both
you,
of
Disha.
them did a great job. Thank you so much.
Thank you.
Thank you.
Thank you.